Good afternoon. This is Sarah with the Department of Medicaid. It's not quite 2 o'clock and we're still clearing the waiting room, so we will give it just a few minutes before we get started. So far, I see Donna, Sherry logged in. If I missed anybody, let me know.
I know Dr. Smith is going to have to leave us a few minutes early, but I feel like she was going to join us. So,
And Natalie emailed me just a little bit ago asking me to resend her the link. Oh, and she's logging in now. And
thank you.
so is Dr. Smith.
Will 4 put us at quorum?
Yes, ma'am. Excuse me. I believe I also saw Amanda log in. It's just now 2 o'clock and we're still clearing the waiting room. So if you'd like, we'll give it just a second. And here comes Alicia. So it looks like,
Okay,
I
great.
believe all your members are present
Great.
today.
Okay, excellent. Yeah, we'll let you clear the waiting room. Just let me know when they're clear and we will get started.
Okay, Donna, it looks like the waiting room is now clear. So I will
Okay.
turn it over to you.
Thank you. Welcome to everyone, and welcome to the members of the TAC, as well as the representatives of the MCO. If you could, if you're a representative of the MCOs or of Medicaid, if you could just give us your name and affiliation in the chat, I would appreciate it. It does appear that we have a quorum for today's meeting. So the first order of business would be for us to approve the minutes from both the October meeting and the January meeting as well. So if I could have a motion to approve the minutes from the October meeting.
I move to approve the minutes from the October 9th, 2024 meeting.
And could I have a second, please?
I second.
Okay, all in favor? Aye.
Aye.
Okay. Any opposed or any corrections? Okay, wonderful. And I do want to thank all the members that are here today. I really appreciate you all taking time out of your busy schedules to be at the meeting today. So thank you for that. And then we need to approve the minutes from January the 8th, 2025. Do I have a motion to do so?
I move to approve the minutes from the January 8th, 2025 meeting.
All right, and do I have a second?
I second.
Thank you. And all in favor? Aye. Any opposed or corrections? All right, thank you. The minutes from the last two meetings are now approved. So we'll move on to old business. We were going to have a follow-up on Medicaid services for incarcerated youth. Is someone here to help us with that?
Give me 1 second, Donna. I apologize. I'm trying to scroll and mute people and still let people in from the waiting room.
Oh, okay.
I'm not seeing anyone. Let me give them a quick nudge. If you want to move on to the
Sure.
next one, if Dr. Cottle is on.
Is Dr.
Or-
Cottle on or someone from the Dental Association? I know we were going to try to have a follow-up. For those of you that weren't at the previous meetings, there were concerns about significant delays in the ability for OR time or emergency care for oral health emergencies. There at one time was a delay of several months for these children to be able to get into the OR for those procedures. And we were going to have a follow-up from someone, hopefully Dr. Cottle, but I don't know that I see Dr. Cottle on here. Or if anyone, a representative of the Dental Association is here, who can maybe give us some follow-up on that. Okay, that will be something that will move forward to the next meeting.
Hey,
Just,
real quick, I don't know if you know, this is Dr. Rich with United Healthcare.
yes,
I don't have any necessary follow-up because I wasn't aware of the original question that you were asking Dr. Cottle, but I'm the dental director with, again, with United. And, you know, there is an access issue for kids across the state, and it doesn't matter if it's Medicaid or not. So just, I mean, for just for perspective, we all know that there are um, challenges getting kids into ORs. Now, they are, I will say that the multiple practices across the state are looking into alternative ways to treat kids that I think are going to help us out in this arena a great deal. I've seen pediatric offices collaborate with pediatric anesthesia services or create their own entity to do that. And there's 4 or 5 of those that, again, so they did do those OR cases in the pediatric offices. And I think that brings a great access. And it's also, you know, more conducive to dental care. So we're starting. There are new opportunities coming up, and but still as per OR time. If that's what you're saying, there are still some significant challenges to compete for dentistry to compete for OR time at a lot of our larger institutions and pediatric OR time. So it's specific, right?
yes.
But and as far as now, if it's related to emergency care, and if you're interested in ED visits, that's kind of a different scenario. But if you want to pose a question, I really wasn't sure exactly what data you were looking for or what, and so sorry I just kind of jumped in and started spouting stuff. But I'm happy to try to provide you with additional information at the next meeting or any time if that could be some help to you.
Okay, yes, I appreciate that. And I do feel like this is an issue that we've been aware of for some time. And our interest is just, is there something, I'm sure the dental TAC is addressing this and trying to come up with solutions, but is there something that we could, either by making a recommendation to the MAC or making a recommendation from this committee to see if there are other options for solutions to help this issue be better addressed. So it sounds like you guys have already started working on that, and thank you for letting us know that.
Yeah, and I'll be happy to pass that request for information on to the dental association as well, and see if Dr. Robertson was on or not, but I'll pass that to them too, so they get to have that opportunity.
Okay, thank you.
Thank you.
Any other questions about that or comments? And thank you for joining in and giving us the update that you did.
Donna,
Yes.
Angela Sparrow has logged in and she will be able to give you an update on incarcerated youth. She's logging in, so if you want to give her just a moment
Of course.
to get in, and then we can address that topic.
Okay. Any other comments on the OR delays or difficulty with access? Okay, we will give Angela just a minute to get logged in, and then she can give us an update on Medicaid services for incarcerated youth.
Good afternoon. Can you all hear me okay?
Yes.
All right. Yeah, I can provide a quick update if that's all right. Thanks. So again, Angela Sparrow, I'm one of the technical project specialists within the Department for Medicaid Services, working primarily on the 1115 demonstration initiative. So to provide, again, update on some of the incarcerated or again, justice involved initiatives within the department. We are continuing to move forward towards implementation of the Reentry 1115 demonstration. Again, that demonstration does include the adults in our state prisons and our youth development centers. We are still targeting a 10/1/2025 implementation date. We are kicking off. There's lots of work groups that are going on again around developing the case management service that each of those individuals would be eligible for in the pre-release time period. Again, to be provided and overseen by our managed care organizations, and then collaborate with our justice partners for developing that plan for that individual, identifying those needs that they would need upon release. And so again, making sure that we have that plan developed before that individual is released so that we can carry that out once they are released. So work again around that. Lots of work right now, again, identifying system changes. So again, where we are integrating more with our healthcare system and our correctional justice system, we can imagine that is a big change, not just for our policies, right, but for our systems to allow for that. So for some of those data exchanges, identifying eligible individuals, how we're identifying them in that appropriate pre-release time period for us to be able to reimburse for those services. So again, working through some system changes there. Gearing up for readiness assessments in the summer. So each of the correctional facilities that participate in the demonstration are required to go through readiness assessment. So ensuring that we have the policies in place to support implementation, those system changes, all of those things are required to demonstrate to CMS that we're ready to go and implement. And so again, we continue to move forward in that, and again, still targeting that 10/1 go live date. With that being said, we're also incorporating and continue to work with CMS around the CAA, the Consolidations Appropriations Act, and that mandatory section that went into effect January 1st. And that is, again, for a more targeted set of population, those eligible juveniles that are defined as under 21 years of age or in our former foster care category up to 26. So again, that's more targeted to those screening and diagnostic services 30 days prior to release, in that targeted case management service. So again, trying to work through aligning, working and progressing towards aligning that initiative with the reentry 1115 rollout, because we're going to have some populations that overlap, and then there's going to be some populations differences there between those authorities. And then the CAA again is also including our local jails. So we are continuing to outreach with our jails. We're pleased with the feedback that we've received thus far from the jails that have responded, but connecting with them one-on-one, really to understand how they may currently align with the CAA requirements, and what are those needs to be able to come on board to support providing those services, which most again are in some form or fashion providing services, but how can we support reimbursement for those, and again kind of get them up to the Medicaid criteria to bill for those services. And so looking to kind of onboard a first cohort of jails and target a first cohort through the summer, and then hopefully get them on board with that 10-1 implementation, and then a second cohort in kind of the remaining jails, if you will, later this year, and even into first of 2026. But as you can imagine, with the volume of jails across the state, and again, this would be significant change for them. We continue to work through on what those models look like, and how we can support them. So I know I threw a lot at you in a little bit of time. So I'll pause and see if you have any questions.
Does anyone have any questions?
All
I
right.
guess my
Oh,
one
go.
question is, do you see anything with the changes at the federal level affecting this project at all?
At this time, Donna, again, we haven't had any indication otherwise, or any feedback that would again say that there would be any impacts with us moving forward. So right now we continue in that direction, but we still have open communication and channels with CMS. So those are all good things.
Good, thank you.
You're welcome.
Any other questions by the TAC members or any of our MCO partners? Okay, I think the bulk of our meeting is going to be learning about adolescent preventive care incentives from the MCOs. And we're going to shake things up a little bit today and not go in alphabetical order. So Erin, I'm going to let you take over and just request information from the MCOs in the order in which you are going to do. So.
Yay, I thought it would be a little fun to shake it up a little bit and give some of those middle MCOs the opportunity to be first. So we're going to start with Passport.
Hey, Erin. It's Jessica Beal from Passport. Am I enabled to share screen? Do you know? Let
Yes,
me
ma'am,
try.
you should be a co-host.
Thank you, ma'am. Give me a second to center something so I can still see you all. There we go. Can you all see my screen?
Yes.
And I assume you can still see my screen as I continue to play with toggles.
Yes, we can
As
see it.
Thank you, ma'am. As I said, I'm Dr. Jessica Beal with Passport by Melina. We're going to go over the request for adolescent preventative care today. You guys asked for some data around well child checks and immunizations, so we'll tackle that first, and then I've got some simple slides specifically on those value-added benefits or rewards or incentives as you requested. So the first thing you guys asked for was data around adolescent well care visits. We appreciate that you understood that we don't have full run out for 2024 data and allowed us to present on 2023 HEDIS, which is complete measure sets for you. So you can see something with, guaranteed accuracy that we wouldn't be able to report quite yet on 2024. We did our best to break it out into the ages you all requested for you. So you can see the totals here on the bottom left. But then I also like to break it out so that you can see kind of how we look at things. We always look at our data set for equity issues by region, race, ethnicity, gender, etc. So I thought that might be helpful for you guys to have access to. I'm not going to read this to you, but I will tell you we see the same things you do as providers, right? We see great engagement in well child visits in those early years of life, and then it slowly peters off the older our kiddos get. And we actively work to try to tackle keeping those kids engaged, especially when it's visits that aren't related to an immunization, because we do tend to see a tick up during those years that kiddos might need immunizations for school reasons, and then a drop off the very next year. So we see similar rates with our adults as well, and that big decline once we see kiddos become theoretically more autonomous. We send letters and reminders as they age out of EPSDT that specifically say, don't forget to stay engaged in primary care visits and do these things, because we know that that transition time is so important. Any questions about adolescent well visits? Or Don, are you okay if I just move through the slides and save them for the end? Okay, I will do that. So adolescent immunizations, we have these broken out for you by the 3 that are required during this time period for IMA. So you can see IMA combo 1 and combo 2 here. We always have this drop with combo 2. HPV is what pulls us down. HPV is very low. We do not like this gap. HPV immunizations for Medicaid kiddos are significantly below the state average as a whole. This is something that Passport has been actively working on for the last 3 years, I believe, trying to move the needle on increasing HPV vaccination specifically. I also had a call out, even though it's not a HEDIS measure for you, because you may wonder about that later adolescent meningococcal booster. Because we don't have HEDIS data, this was kind of an unusual data pull for us. We simply looked at 16-year-olds to see what percent had gotten that booster in 2023, and it was right around 30%, just so you guys are aware. Again, breaking out the HEDIS measure for you. And looking at our regional data set and by race, ethnicity, not a big surprise here. I would like to remind the group that, Passport is really, really heavy and dominant in what is region 3. About 78% of our membership for this denominator is in region 3, was in region 3. So that is a really big chunk of our adolescent membership is in that region. We focus a lot of efforts on that region, but we are always looking to see where we may have some other challenges, even though our population is lower in other regions. And I will say that year after year, we do continue to find that rurality seems to be somewhat of an independent variable in immunizations, even when accounting for the poverty that we would expect to see with our Medicaid members. So we do work hard to try to give our members some incentives around this, and you'll see on the subsequent slide our providers. So this is a breakout of just our healthy rewards for the adolescent population you all called out. We have many other healthy rewards, but I wanted to make sure you could see just those kiddos. Because of that slide that we see in adolescents with well child visits, in 2025, we decided we would increase the healthy reward for our 13 to 21-year-olds, hoping that might drive some more of our members into care, or at least make them feel rewarded for the care they're getting. So while last year that reward was the same as our 3 to 12-year-old members at $25, we decided to increase that this year, and we will be looking to see if there's any impact from that once we get through the year, since we consider that sort of a new incentive. There's also our annual well child visits for our younger kids. So those 12-year-olds squeezed into that. So I put that on here for you. Yearly chlamydia screening is also something that we provide a reward to for our members. And then, of course, the annual dental exam, which I know you all talked about dental issues earlier, but we, of course, want all of our members, children and adults, to have healthy teeth and gums. And so that's a $50 gift card credit for anyone that gets their annual exam. We encourage our kiddos to get 2 annual exams a year, but we only incentivize the first one of the year. For HPV, as I said, this is something we've been working on for a really, really long time. Passport believes firmly in approaching HPV from an on time at 9 mindset. And so we provide a lot of information to our providers, and we are working with our members starting at the age of 9 on that HPV vaccination. And so we offer a $50 gift card credit for each of the doses, so $100 max. For our kiddos ages 9 through 12 who receive and complete their HPV immunizations. And then, of course, all the MCOs are requested that we work on getting health risk assessments completed for our members. That applies to every one of our members. That information is really helpful. It helps us see what our members might want and need from us. It gives us information we may not always have at our fingertips. And we do respond to our members based on the HRAs that they send in, and that's a $25 gift card credit. For our providers, that are in our value-based contract, we have 2 HEDIS measures that we incentivize on specifically for this adolescent population. The first is those well visits, and the second is the adolescent immunizations. But again, we have been focused on combo 2 because we know that HPV is really where our kiddos in the Commonwealth are lagging behind, and we are focused on trying to boost that up. As a result, in 2025, we have sort of added an incentive for HPV. All providers are eligible for this incentive, and that is an additional reimbursement for each HPV dose administered between the ages of 9 and 12 for the patients that they serve. So folks in our value-based can kind of double their dollars there, but all of our providers can take part in this incentive. And that's all I have. Does anyone have any questions for Passport?
I guess my one question would be, how do you let your members know that those incentives are there?
Yeah, so multiple methods. We make sure that it's provided in our member newsletter. We have it all on our website. As the named EPSDT coordinator for the health plan, I actually reach out to several of our providers at the beginning of every year and make sure they have the attestations, and that I answer all of their questions about what rewards we have, specifically in that pediatric space. And then of course we have our community engagement team that goes out into the community and advises our members, and our care managers advise our members when they speak with them as well, as does member services when members call in and ask questions. So we try to make sure that we can kind of plug and play in lots of spaces. And then of course the member portal has the information as well.
Okay, thank you.
You're welcome.
Etna, you're up. Amanda, you're on mute if you're speaking.
Can you hear me now?
Yes, ma'am.
I'm so sorry. Oh my goodness. My Teams, my microphone is broken. So I assumed on this it would also be broken. So I was on my phone. So I
Oh,
apologize.
no worries.
I was just talking away. All right, I'm going to try this again. And we're going to see if I can get my screen to share appropriately. Okay. Can you see my PowerPoint?
Yes, ma'am.
Awesome. Okay. Well, we will go ahead. Let me see if I can do it this way. All right. Okay. And can you still see it?
Yes.
Awesome. Okay. So I am not Megan Johnson. She is actually not feeling well today and under the weather and has asked me to present for Aetna today. My name is Amanda Markham. I am a nurse in the quality department with Aetna. So I will be presenting our slides today. And again, as Jessica stated, thank you for letting us share 23 rates since HEDIS measurement year 2024 is actually just getting ready to be pencils down. And of course, we won't get those rates until later in the year. So we are able to share our 2023 rates to give you our final rates for that year. And we were going to start off with our weight assessment and counseling. So we've broken it out by age and by each individual part of the WCC measure. So as you can see, we've got our 3 to 11-year-olds and we've got our 12 to 17-year-olds and then we have our total. So we're showing that for our BMI, our counseling for nutrition, and our counseling for physical activity. And as you can see, the rates for BMI are great. Those doctors are getting on the claims and getting those codes down for the BMIs. Our nutrition and physical activity is a little on the lower than the BMI. I feel like that's probably what I have found in my time with quality is more of a coding issue and making sure that they're getting those codes on claims and getting them sent in. But again, not super low, but doing well, just could be a little bit better like the BMIs. And we will move on to our W30, which is the well child visits in the first 30 months of life. And we've broken those out, of course, as the HEDIS measure does by age. So the first 15 months, and then the 15 to 30 month of life. And you can see our rates for 2023 are 61.93 for the first 15 months and 69.37% for 15 to 30 months. And then we have our WCV. So this is, our kiddos who are 3 to 21 that we're wanting them to get in and be seen by a practitioner during the measurement year. And our rates, as you can see on here, and it's kind of like Jessica said, with the same as Passport, as the kiddos get older, they tend to not see the need and want to always go to the doctor for their follow-up. I think sometimes when they don't have parents pushing them along, they don't always go. I know that personally with my own. But you can see the young ones, the 3 to 11-year-olds, they're at 55%, and then starts to kind of drop between 12 and 17, and then definitely drops a little more those 18 to 21-year-olds. And then we have our total of 47.23%. And then we have our IMA injections. So we're looking at our kiddos and we're wanting them to get their injections before their 13th birthday. And again, it is that HPV vaccine that really seems to drive the numbers down. I think sometimes we see either not getting it or sometimes getting the first one and never completing the series and getting the second one. Our meningococcal and Tdap are doing good at 80 and 83%, and then like I said, that HPV drops it down to 28%. So as our combo 10, we're at 26 But as a combo 1, leaving out that HPV, we're at a 79. So again, that's just like I said, that's a hard one to get for that age. And like I said, a lot of the times they'll get the first one and then you just can't get them back in there to get the second one. And then for our CIS combo 10 and combo 3, you can see our numbers here looking pretty good across the board until you get down to that flu vaccine. And again, as we all know, because it's talked about a lot on a lot of calls and a lot of meetings across the state, that is a low it's a low number for all MCOs and plans. Just a lot of trouble getting buy-in from parents. I think that it is needed and that the importance of it. So that right there is at 25%. And like I said, you can see the rest of them. We're in the 70s and 80s for the most part. So our combo 10, of course, because of the influenza, drops down to 19. We do, as the other one mentioned, and I'm sure most of them do, we do a lot of calling and sending out, text messages, and our case managers working with the parents and the guardians, about the importance of it. We do education to our providers. We do education as far as who is compliant, who isn't compliant, who's, needs what vaccines, sending them out. As far as, these members are going to be turning 2 this year, they still need these vaccines before the end of the year, to try to get, the buy-in from the providers, also to talk to the parents. And then as far as incentives and outcomes, what we offer for the annual well visit, we're offering a $25 incentive gift card for completing that. For completing 6 well child visits before the 15 months, they get $50 gift card. And then a $50 gift card for participation in after school activities. So they can get a $50 gift card if they complete their well child visit in the last 12 months, a $50 gift card to help pay for 4-H, Boys and Girls Clubs of America, Boy Scouts, Girl Scouts, those type of things, to help with after school activities and give the kids something to do for activities and health and well-being. So that's another opportunity they have. We offer $25 for completion of the HPV vaccine series if they have it before their 13th birthday. If they'll get both of those vaccines, they get a $25 gift card. $25 for completion of the 2 infant flu shots is another one that we are offering to our members. $25 for completing the metabolic screening if they're prescribed an antipsychotic medication. And then we also offer the $15 a month monthly stipend for over-the-counter benefits. So our members can get online and order or call and get things like Tylenol and Band-Aids and thermometers and things like that they may need and not have to go to Walmart and spend their own money on. So that's kind of what we're doing. And we do offer, all of ours are online, as far as the members can go and online and view all of them. Our case managers ensure that our members know which ones are they're eligible for. When members call into member services, our member services discuss with the member or the parent guardian what opportunities they have for extra incentives, as well as discussing with them what open care gaps they have and what is still needed for the year for the child or the member. So that is some of the ways that we reach out and touch our members, letting them know what is needed and what's available. And then just kind of a year over year showing where we're kind of, looking up from 2020 to 2024 with well child visit outcomes. You can see down through there all of our WCV, W30, WCC on down. Definitely year over year, we are trending up, with WCV being, BMI definitely being the highest trend up. And all of them looking really good. So you can kind of see that year over year for the last few years. And then we've got, again, just our kind of just pointing out, as we all know, it's statewide as far as the compliance with the combo 3 and the combo 10. So just kind of showing what the national average and then what Aetna's combo looks like. And again, it is trending down, but again, that is across the state. Same over here with Kentucky MCO and then Medicaid as a whole. So let me move on. And that is all that we have for you. Does anyone have any questions? Anything I can answer or elaborate on?
I do see a hand up.
Okay.
So if you would like to ask your question.
Yes, hi, thank you. This is Rachel Rare with DMS, and some of those slides kind of popped a question in my mind. I was hoping you could clarify. It said on there for the value-added benefits that are offered, gift cards, things like that. A lot of those, before they're eligible, they will have to be verified as having, completed a checkup visit or completed an immunization. And that got me thinking there. So if the provider is really on top of it and says, hey, you just got this immunization for your child, make sure that you call your MCO. How long would it be before you all could see that visit to validate that they would be eligible? Should they wait a certain amount of time? Could they call directly after? Just curious about that.
And I think it's kind of based on provider, because it's going to be when the provider submits their claim. So as soon as the provider submits the claim and it comes through to us, because I know a lot of times when the member calls, if they call member services and say, hey, I went to the doctor today, I got my well child visit, member services will pull claims to see if we have a claim for that visit or not. If we do, then we can go ahead and, get that gift card going to them. And if not, then we do have to wait on the claims to come in from the provider. So kind of just a matter of how quickly the providers submit their claims.
So at that point on member services, would they be directed, call back in a week, call back in 2 weeks? What would that look like?
Honestly, I am not sure what they are directed at after that. I can definitely find out for you. I know anytime that I don't speak to them, but when I get emails from member services, saying this member called, I will let the care manager know. If they have a care manager, I will let them know, hey, this member called, they were, wanting this, and just let them know to reach back out to the member and let them know that we're just waiting on that claim to come through. But as far as timeline, I'm not sure, but I can definitely find out what the member services, what their timeline is and let you know.
Yeah, thank you. And this is not picking on WellCare at all. This is, a note for all.
No.
It's something to keep in mind that, that we've noticed that could help members if they have some type of direction on when to call back or something like that. That way they don't just give up and don't call.
Oh, agree, 100% agree. Yes, and definitely I can find out what we do as far as that goes and what the timeline is.
Great. Thank you so much.
Thank you. Any other questions? Thank you all so much.
Thank you.
United. And Dr. Cantor, you should already be a co-host. Oh,
Good
Grace, I saw you
afternoon.
come on camera. Do you need to be a co-host?
Yes, if possible.
Okay, sure.
Yes. Thank you.
You're very welcome.
Thank you, Erin, for having us. I'm
You're very
Dr. Cantor.
welcome.
Yeah, I'm Dr. Cantor, the CMO with United Healthcare, and Grace is going to help us with presenting the information here. So I'll turn it over to our EPSDT coordinator. Thank you.
Am I available to share? I'm trying, but it's
Yes,
not
ma'am.
allowing. Okay, just one second. I think I've got it. Can you guys see the presentation?
Yes.
Okay. Dr. Cantor, would you like to do the opening remarks or?
No, you're welcome to take it off from here. We're good.
All right, thank
Thanks.
you. I was focusing on getting the presentation pulled up, so I wasn't for sure. So thank you. I am Grace Nelson. I'm the EPSDT coordinator. And the 4 measures we focused on is well child visits, immunizations for adolescents, combo 1 and combo 2, and weight assessment, counseling for nutrition, and physical activity for children and adolescents. Again, we went with the measurement year rates 2023, and listed here on the screen, you can see a measurement year rate for each of the previously mentioned measures. Our rates are trending up in 2024 compared to our 2023 rates, and we are working to continue our rates through member and provider incentives and programming. Here on the screen is some of the information on the member and provider incentives and programming used to drive our rates up. We have a $25 member reward card that is accessed through member services. We have reminder mailers, text, emails, and live agent calling to assist with appointment scheduling. We provide education at community events and health fairs. We have our CP-PCPI, it's our provider incentive program, which is a per gap in care payment. We have value-based care programs that align quality gap targets. And lastly, here's a screenshot of the communication we have developed in 2024 to promote IMA Combo 2, focusing on HPV. And thank you all for your time. And if you have any questions, Dr. Cantor and I will be happy to try to answer those for you.
Does anyone have any questions? Thank you all.
Thank you.
Thank you.
WellCare, your turn. And Stuart, you should be a co-host.
Thank you, Erin. Good afternoon, everyone. Let me share real quick, which kind of hold my breath because my incompetence comes through. Technical incompetence. Can you all see presentation?
We can.
Thank you. We don't have anybody from quality on the call today that's available today, but so I'll be going through the slides. So the first slide, we've got the immunization data, the well child well care visits. You can see HEDIS measurement year 21, 22, 23. Fortunately, things improved. In the most recent, of course, I know the 24 data won't be finalized till I think mid-June, but year over year from the prior year, we're green on everything, which is really hopeful, really positive. I know, obviously, I think everybody during the pandemic, everything suffered and related really immunizations and well care visits in 21. So anyway, things have improved last year. So that's very positive. I know immunizations in general have been a challenge because a lot of misinformation, I guess, that came out of COVID. So it's been a huge challenge for all of us, all the MCOs, and we've done a lot of efforts, a lot of initiatives, and I know that all the MCOs have done as well in the past 2 or 3 years to try to figure out what's the solution here. A lot of it's just critical, the messaging, I think, with, in particular, I think, younger female moms we've seen. So there are new things that have emerged, new barriers basically that have emerged since COVID, I think, that make it more challenging. But we're all, I think, trying to figure out what are the solutions to that. So the next slides, I'm going to walk through our incentives, what we're trying to do. So first, here's just kind of our general what we do overall for My Health Pays, and this includes, you can see, like the wellness exam, dental cleaning, annual screenings, childhood immunizations. Then we get a little bit more detail. And so for adolescent immunization 12-13, you can see the different ones there, the meningococcal between 11th, 13th birthday, HPV between 9th and 13th. You get points, or you can choose products, and we'll get at the end. You're like, well, what are the points? So what are points? But we'll get to the end to see what you can obtain with the points. So 1 to 17-year-old metabolic monitoring, for 1 to 17 taking antipsychotic meds, and completing the glucose and cholesterol testing, and that's actually something that we've been really concerned about. Is the kids on the antipsychotic meds, but there's no evidence that the monitoring is going on? That's like a very huge concern. I'm not a clinician, but talking to our staff, that is a very huge concern that they have, like a low percent of prevalence of that actually occurring. It's like the children are getting the antipsychotics, but where's the evidence that you're actually monitoring it? But anyway, so that's eligible 250 points. 3 to 20-year-olds, that's where you get the dental cleaning, will qualify you, $75 Nike gift card or 750 points. And then this is kind of a repeat. This is a grid of kind of what we're talking about before. The same thing, 320, 1 to 17, what qualifies you, and the information. And so I believe that we can, and I'm not certain, but I think, like to the earlier question, if somebody, I believe there's a form, if they can submit, not just a claim, but I'm not positive about this, but I think if we could get some kind of attestation, essentially, that could be used to validate. I'm not positive, but I believe that. That would be another way, not just the claim. I mean, I think it is primarily claims based, but I think that is an option. And so again, the 12 to 13-year-old, which what were the different immunizations that we're talking about before. And again, we got the adults, specifically dental sealant, 6 to 14, 100 points. Tobacco cessation as well, threw that in there. 12 and above. So if you complete that, also that qualifies. And so at the end, we do have one of the things we have is a brochure, like an online brochure of a lot of items that people can get, but these are the different categories of stuff that you can get with those points that you can earn, that you can choose, that you actually obtain based on how many points you earn. And that's it.
Okay, thank you. Any
Sure.
questions?
Hi, this is Dr. Terrio. It's not really a question. It's more of a thought, but since Stuart, you brought up the metabolic monitoring.
Yes.
I wonder, as a primary care pediatrician, people would bring us, orders on a prescription pad from the psychiatrist asking us to do the labs. And we didn't because we are not a commercial lab, so they would have to go to a commercial lab to get that done. We wouldn't do, somebody else's orders. But the other thing is, if the psychiatrist is ordering those labs, they're going to follow the labs. So they're going to get the results. They're going to increase the dose, decrease the dose, change the med, something that the primary care pediatrician is not going to do if they had, lab results, because they have no control over that medicine. The psychiatrist is doing it. And so I wonder if there are orders, for the labs, for metabolic monitoring, that aren't getting done because they are bringing it to the wrong place. And when I asked patients, they said the psychiatrist told them to go to their primary care physician.
Okay.
So I don't know if that maybe is an educational thing to the psychiatrist to say, bring it to a commercial lab, not the pediatrician. But I don't know. It's just a thought.
Yeah, no, I mean, that's a great point.
What are your thoughts, Dr. Grigsby? Do you kind of see the same thing, or?
I don't. And I don't know if it's because our psychiatrists are following those. The psychiatrist outside of the UK system, I guess, may be using different labs because And I would think the ones within the UK system would be using our lab for those, but I don't know. It's not an issue that we encounter very frequently, to my knowledge, in my practice.
It was just a thought, maybe, hey, a
Yeah.
little education
Yeah.
and it would improve.
I can certainly reach out to one of my colleagues that's a triple board person, just to say, hey, what do you guys do with these labs? Like, where do you send these labs? Who's following these labs? Because I can't recall having that kind of encounter with a patient. So maybe
Okay.
they're going through a different system, or maybe they're going through, and doing them on their own. But I can check on that. That's a good question.
Good thought. Mhm. It feels so short. Thanks.
Any other questions or comments?
I have one. It's Jeb Teichman from Passport. We have also have a problem meeting that HEDIS measure of ABA. And it's kind of a circuitous argument. It's we hear the psychiatrists don't want to order the labs because they don't know what to do with the results. The pediatricians say the same thing that Dr. Terrio has said. They're not prescribing, so they're not responsible. We've actually reached, I think I've had better luck actually reaching out to the pediatrician, the PCP, to ask them just to get order the labs, draw the blood, send them someplace, get the results, and coordinate with the psychiatrist. You're on mute, Judy.
Sorry, maybe that's what we have to do.
I mean, if you collect the med list when you're seeing the member, and you don't see the test in your chart, there's no harm to duplicating it just to
Mhm.
get that done. We'll meet the HEDIS measure, and we'll
Right.
find. I'm sure you, as well as I, had many children on antipsychotics. I wasn't prescribing, but I've
Mhm.
even had to put a couple on metformin when I was seeing patients, because
Mhm.
you know who's got a problem when you're seeing them.
Yeah. True.
Okay, any other comments or questions? Thank you. Thank you for bringing those issues up.
And that leaves Humana.
Hello. Hold on, let me share my screen. Y'all can hear me, right? Can you hear me?
Yes.
Yes.
Okay, great. Okay. Hi, my name is Paulette Mitchell. I'm a senior quality improvement professional here at Humana Healthy Horizons in Kentucky, and I'm going to go over similar to what everyone else has went over. When I talk about the HEDIS measures that are to this age group, we really concentrated on the 12 to 17-year-olds, and our individual Humana measure metrics for 2022 and 2023. And then I'm going to show you some of the coverage for this age group and the value-added benefits and resources for this age group. So for our HEDIS measures, we concentrated, because of the age group that we're looking at, we concentrated on the WCV, the WCC, which had the sub-measures of the BMI, the counseling for nutrition, and the physical activity, and the IMA, both IMA 1 and 2, combo 1 and 2. And the definitions are here. The WCV is just the assesses members 30 to 21 who have a well child visit that year. And WCC, it assesses children between 3 and 17 who had an outpatient visit with the PCP or OBGYN, and the BMI, or in the counseling for nutrition and the counseling for physical activity, are collected at that visit. And IMA looks at the meningococcal, Tdap, and the HPV series by their 13th birthday. So for 2022 and 2023, You can see for the 12 to 17-year-olds that our rate, we did perform better year over year. And like someone mentioned before, BMI is really high. And the counseling for nutrition and the counseling for physical activity, even though we did perform better year over year, they're not quite as high as the BMI. And I do not believe that it's because these conversations are not being had, it's just not coming in as claims. So it's more of a data gap than an actual care gap. And for the IMA, for the 13-year-olds, IMA combo 1 is the Tdap and the meningococcal. That one's always higher. And then the HPV series is added on to that combo 1, and that one's usually lower. And like everyone else, there's trying to figure out the magic to get those both HPV series in before they're 13. I don't think any of us have quite figured that out yet. For coverage, these are some coverage that I pulled out for 12 to 18-year-olds. We cover the annual visits, immunizations, preventative care, emergency care, the sports physicals, and the behavioral health services. Those are the highlights of what we cover for this age group. And if anyone wants any more information, it's in our member handbook for every single thing that we cover. So our Health and Rewards program is our Go 365, and these are some of the highlights for this age group. And you do the healthy action and you get a gift certificate for this reward amount. And so for your annual visit, your HPV vaccine, that's both vaccines, the flu vaccine, and that's all ages. And then these, and I've added this up and it's over $200. So when talking to members, and I've talked to members, and this is a really great thing to call someone and I can start out the conversation with, you can get $200 and even multiply that if you have several children. So that's a really good benefit and it's a really good conversation starter. For more of our online, we have Kids Health, and it is a online type of library, and it has advice and tips, and it has articles for parents and for children as well. And there's games, and there's videos that are age appropriate as well. So those are just more topics or questions. I've seen questions as far as how to help my child sleep longer, things like that. Just tips and things like that. And our weight management is it is up here with the incentives, but our weight management, it is highlighted all the time because it's one-on-one support for kids 12 and up. And the thing that I really like about this is it meets kids where they are. So it doesn't just say, hey, go do this, this, and this. It's really a conversation with a coach. And it's 6 sessions with the coach, and you progress based on your needs and what you want to do. And this one's really highlighted, and this one had a lot of success. Any questions?
Thank you. Any questions, comments? All right. Thank you to all the MCOs for your presentations. I feel like we all realize that we have a lot of work to do around immunizations for adolescents. And, I agree with what I think Stuart said. We have just seen such a huge backlash after COVID about immunizations, and we continue to struggle with kind of how to overcome some of the misinformation that's out there. So thank you all for all of your hard work and your attempts to try to get patients in for care and for providing those resources. Any other comments or questions before we move on? Okay. The meeting schedule, again, just a reminder, our next meeting will be July the 2nd. And our October meeting will be October 1st. Those are both Wednesdays. And we'll move to any new business. Does anyone have any new business? Okay. Again, we need to, under general discussion, just any future topic suggestions. So anyone on the TAC, do you all have any discussions or questions that we need to have addressed in our upcoming meetings?
Donna, I am not a TAC member. This is Erin, but I do have in my notes when we sent out the original HEDIS request, and I do want to thank the MCOs for reaching out to me because I am not a subject expert and did not realize that 2024 would not be ready. But you had, when I asked you to clarify the year, you had mentioned maybe in the July meeting we would request for a presentation for 2024 in October. So I didn't know if you wanted to make note of that under kind of a continuous just mention in July so that in October the MCOs would be ready.
Yeah, if we can add that when we work on the agenda for next time, we can certainly do that. Thank you.
I just want to add that this is Angie Parker with Medicaid. It may not even be ready by October. Depends on when the meeting is in October. But yeah, 2024 HEDIS measures, we're currently in the HEDIS period of getting data and obtaining data and getting it analyzed. So it takes a little bit.
Okay. Is October a realistic, the 1st of October, is that realistic at all?
I think it might be pushing it.
Okay.
There's
So
a
this may be-
possibility. So maybe the December meeting.
Or January. Yeah, we'll have a meeting in January of 2026.
Thank you, Angie.
Okay, thank you.
You're welcome.
Any other topics for discussion?
Hey Donna, this is Alicia with KYA. I'm not sure when this might make sense for this group to maybe request data on. It certainly would not be in July, but just looking forward, I think I heard at a recent update call from DMS that they're just now kind of getting to the restarting renewals for children's Medicaid coverage related to the unwinding from COVID, suspensions. And so I was just curious if now that they're kind of getting into that child space of coverage, if we wanted to have that on our agenda in the future to maybe see how that's going, check in on if there's been coverage gaps or loss of coverage, and get a picture of that at some point.
No, I think that's an excellent suggestion. From the folks from DMS, when do you think it's realistic that we can see the impact of that change? If there is an impact.
Do we have anyone from eligibility on? Alicia, they may be able to give a brief update in July, but might not have more information till October. I can reach out and maybe get a better time frame for you guys if that works.
Sure. Yes, please. Thank you. Any other questions, comments? Any other future topic suggestions? Okay, I guess my question to the group is, if we're not going to have data from the things that we're interested in, is there a need for a meeting in July? I don't want to cancel meetings. We only have meetings quarterly, but right now we have no items for discussion. How does everyone feel about that? I don't want to have a meeting where we're trying to discuss things if there's nothing to discuss, I guess is what I want to be respectful of everyone's time. I don't want to cancel meetings if there are important things we need to discuss, but I'm hearing that those things that we're most interested in, we may not have data available to us by July. So I guess, Erin, my question is, if we reach out to our folks about when it's realistic, and we see that maybe there should be an update in July based on eligibility and gaps in coverage, that maybe that's something important for us to address. But if it's not realistic that we're going to have that information, should we postpone or should we cancel that next meeting and just discuss it in October?
Well, my recommendation would be, and of course, it's solely up to the TAC members. I will reach out for clarification on the reporting month, which would be best. And what we could do is I can reach out to you, maybe towards the beginning of June, mid-June, and see if the TAC members have any other items that may have come up since this meeting they would like to address under new business. And if we don't have an update on the continuous coverage for children until October, then maybe make the decision to cancel July at the beginning of June, mid-June,
Okay.
because there may be some items that say pop up between now and then that you may want to discuss or put on our radar.
Okay. I think that sounds reasonable. If we could all just keep the meeting on our calendars so that if we do need to meet, we will all still have that availability. And if we see at the 1st of June that we're not going to have information or that something hasn't come up. And again, I know that we have to be cautious about discussing meeting stuff outside of the meeting, but I believe we're allowed to do that via email to a certain degree. Is that correct?
Yes,
Erin?
ma'am.
Okay.
If there's emails going around that you don't have agenda items or you're discussing agenda items, that falls within the purview of being okay.
Okay. Okay. So perhaps if we could have an email exchange the first part of June, just to see if there are any other issues that we need to discuss or at least put on the agenda. So we will keep the July 2nd meeting for now, with the understanding that if the data will not be ready by that time, that meeting may be canceled. Does that sound okay to everyone? Okay. All right. And then again, we always talk about MAC meeting representation, and there are several of us that have commitments consistently on Thursdays. When is the next MAC?
It is May 22nd.
So I don't know if there's anyone that is available for that May 22nd meeting.
And Donna, if no one is available, you could type up a quick, brief TAC report that we could submit to Dr. Schuster, and then she can notify the MAC that you guys have had a meeting,
Okay.
whether or not you had recommendations, things you discussed. There are some TACs that do that when they don't have
Sure.
someone who can be there.
Okay. Do any of the TAC members feel like there's anything we've seen that would necessitate us making a recommendation to the MAC?
I don't necessarily. I keep nodding and shaking my head, assuming you can see me, but I don't.
Okay.
I don't either. It seems like things they're concerned about, they're working on.
Yeah.
Okay. All right. Any other members of the TAC that have anything to add? So for now, our next meeting will be July the 2nd. But if that meeting, if we see that the agenda is slim or there aren't items that we can meaningfully discuss in July, then we will let everyone know that the first part of June via email. We'll have a discussion about any other agenda items. And then if we decide there really isn't a compelling reason or a reasonable discussion that we need to have in July, we will let everyone know of the cancellation of that meeting. Does that sound reasonable?
Yes.
So do I hear a motion to adjourn?
I move that we adjourn the meeting.
Okay. In a second?
I second.
All in favor?
Aye.
Aye. Okay. Thank you all for your time. We are now getting back 46 minutes of a gift of time. So thank you all for your participation. Thank you to the MCOs for your presentations and to those of you that gave us updates, much appreciated. And hopefully we'll see you guys in July, but if not, we will see you guys in October. If the TAC members will stay on for just a moment, we will